Patient Safety in Primary Care is a learning management system presented by Professor James Reason.
Primary carers are expected to know everything about everything, unlike specialists in acute care, hospitals, that they have to have an enormous range of understanding.
6 broadcast standard programs distill the frontline experience of leaders in the field. The programs are online for immediate accessibility. The accompanying support materials draw on worldwide experience in other areas of high-hazard endeavour. Self-assessment modules support individual study, team development and continuing medical education. Programme 1 engages with the realities of 1 million consultations a day.
Each day in the National Health Service there are 1 million primary care consultations.
There are about 300 million consultations a year between patients and general practitioners. There are about 800 million prescription items written a year. So the opportunity for error in primary care is quite enormous.
People's whole lives are sometimes completely ruined, if not taken away, by avoidable errors, avoidable mishaps in healthcare.
Orthoscale pain to the effect that I contemplated suicide.
When something goes wrong, you need to lose sleep over it. Why did it happen? Do I understand what happened here? Have I made sure that I know the reasons this happened? What can I do to prevent it? Have I said sorry to the patient?
So can we make things better? Yes, I believe we can. With the right leadership, with the right ideas, with the right sense of personal involvement, we can make things better.
Programme 2 is about culture, the foundation of change.
Culture has many definitions, but in essence it boils down to 2 things. Something that an organisation or a nation has in the way of norms, beliefs, attitudes, something that an organisation is. It's to do with the activities, the practices. What is easier to change? Do we change people's attitudes or do we change people's practices?
We need to learn to be shocked again, not to be tolerant of harm.
At the heart of the patient safety problem lies a paradox. On the one hand, healthcare professionals, and particularly doctors, are trained in a culture that marginalises error, that equates error to incompetence. And yet, healthcare activities are among the most error-provoking in the world.
I often make the analogy with tennis, whereby being competent is like having a good forehand. Being able to create effective relationships is being able to have a good backhand. And to be a good tennis player, you need a good forehand and a good backhand.
It's almost putting the love back into the system. Where is the love in the modern NHS?
It makes me feel passionate about being a nurse, and it's why I became a nurse in the first place.
It is so important when something has gone wrong to be open and candid with the patient. It is part of the ongoing therapeutic relationship.
Programme 3 explores error traps in diagnosis.
If we recognise that diagnostic errors are the most common errors that are made in general practice, then I think those are where we need to really focus our attention.
Healthcare is delivered by experts, but there's a problem. Although experts can be very fast and frugal in their decision-making, after a time they begin to think intuitively, and that feels as though it must be right.
Our study found that the rate of diagnostic accuracy across scenarios was 42%, and the rate of appropriate management was about 52% on average.
What are the things in general practice that make the alarm bells ring, that make the hair on the back of your neck stand up?
Socrates, the Greek philosopher, was fond of referring to something which he called a daimonion, by which he meant a little voice that whispered in his head that said, danger.
It is very important that general practitioners do not become too risk-averse, or so risk-averse that they send everyone into hospital.
Some systems are very prone to breakdown. They are very vulnerable. Other systems have a certain measure of resilience, a certain measure of resistance to bad things. So what we're hoping for, the situation rather like the ball in the bowl, where you can agitate, perturb the system, the ball will not fall out. It has a high degree of resilience, and we can't hope ever to achieve a state where there are no bad events, where there are no accidents, where there are no errors.
Programme 4 is about communication.
I think we must appreciate just how powerful Sod's law is. Anything that can go wrong will go wrong.
In safety terms, interfaces of care are dangerous places to be for patients.
Blood test that was done just before the patients were admitted was just within the normal range. But if you'd actually looked back and seen what was happening to the blood test, you could see it was on an upward trajectory.
One of the big issues, I think, is when we order pathology tests and making sure that the results come back to someone who understands why they've ordered the tests and communicates that clearly to a patient.
I owe a great debt of gratitude to numbers of pharmacists who have picked up the phone and said, "Maureen, do you really mean to prescribe this in this quantity or this drug?" And you know, I'll have made a mistake. These colleagues, skilled community pharmacists, have picked this up, addressed it and put it right, actually.
Programme 5 examines safer medication.
Research published on medication error with elderly people in care homes. The results really were very frightening indeed. It found that on any one day, elderly residents in care homes, average aged about 85, were likely to suffer a 7 in 10 chance of a medication error on any one day.
Prescribing drugs is an experiment nearly every time when you have a patient. You don't know how their biology is going to react.
It's reasonable to say that there are people like junior doctors, like nurses, who can't really expect to change the system as a whole. Very few of us can do that. But what they can do is improve their error wisdom to increase the likelihood that they're going to pick up the signs and symptoms that are going to cause them to step back from a situation, to look for help.
Programme 6 is building safer practice. Ideas for you?
For most of the 20th century, and certainly before that, being a doctor was like being a priest. It was the defining characteristic of the individual. And if you wanted to explain the ethos, it would be, being a doctor is what I am. Whereas now in the 21st century, with all these other competing pressures on a person's lifestyle, it's being a doctor is what I do some of the time.
Imagine you've got your population in front of you. What the typologist allows us to do is to apply a lens to that population so that we can look at particular segments of the population in a lot more detail, a lot more definition around their specific needs.
The poorest people with the greatest health need sometimes had some of the poorest services. Honourable exceptions, some really superb practices, but very much islands on their own, isolated, trying to keep going and keep their heads above water. It was so bad that there were quite a few practices who were not remediable, and we addressed those in conjunction with professional regulation through the GMC, the National Clinical Assessment Service, the Deanery, our own powers that PCTs have been reluctant to use, but I think it's catching up now, using the performers list powers, and just to say to people, this is not good enough, you're not up to the job, time to go.
There are two faces to the human factor. There's the human that screws up, the human that makes errors, and then there's the human as hero. And I think we tend to neglect the latter face. And yet the hope for the future is that the many, many heroes that exist within the healthcare system will continue to be inspirational, will continue to lead the improvements that we have already seen. They can make an enormous difference. There is a place for the heroic in the healthcare system.